Now we're going to welcome Di Harvey. I'll let them sort the tech stuff out. That'd be great. Di Harvey today is presenting on the Rural Allied Health Assistance Pilot Program that's run in our district, and she's co-presenting with Katie Pope Devon from Warren, who's coming in to join us virtually. The Rural Allied Health Assistant Project commenced in September 23 across 5 rural health facilities, MPSs, in the northern part of our district. The aim of the Rural Allied Health Assistant Project service delivery is to improve the connection of care for patients, residents and outpatients within rural and remote health facilities to virtual allied health services to ensure patients and residents receive networked and seamless care at the right time. Di Harvey is an OT, occupational therapist and acting manager of the Virtual Allied Health Service for Western New South Wales, and has a very big and a very important job in particularly those sites where there's very minimal allied health face-to-face. She's worked within the private and public sector for over 20 years and a lot of project roles in this last few years. Has a very big passion for rural health and values the challenges of designing services to address the complex problems for future health needs. Katie is the Rural Allied Health Assistant at Warren, MPS, and Warren is located at approximately 130 kilometres northwest of Dubbo. Katie is an active member of the Warren community and was employed as an administrative assistant at Warren MPS, where when the project came up, Katie's desire to make a really big difference in her community when they were at their most vulnerable made Katie the perfect position for the job. Katie had not previously worked with allied health professionals, and there are no allied health professionals at the moment on site at Warren MPS. Katie provides multidisciplinary therapeutic interventions to inpatients, residential aged care and outpatient support, and overseen by the Virtual Allied Health team. So welcome, Katie, virtually, and thanks, Di.
Thank you, Ash. Katie, can you hear me? Oh, yes, there you are. Welcome. So I think this is ticked over to afternoon. So good afternoon, everyone, and thank you for having both myself and Katie, our Rural Allied Health Assistant in Warren, here to present on our Rural Allied Health Assistant program. Like Ash said, this program commenced 6 months ago within 5 of our rural health facilities. Today, we'll just give you a brief introduction to this newly established program and how this model can have an impact targeting function and solutions to reduce falls within the facilities and communities. So before we begin, we would like to respectfully acknowledge the traditional owners of the country throughout Western New South Wales and their continuing connection to land, water and community. And Katie and I would like to pay our respects to elders, both past and present, and extend that respect to other Aboriginal and Torres Strait Islanders that are present here today, face-to-face and online. So our case for change. Placing allied health assistants within rural facilities that have no access to on-site allied health professionals has been discussed for several years within our LHD. However, managing the risk around scope of practice and accountability was always considered too high. There has also been previous attempts to recruit AHAs locally without any allied health professional oversight. However, this has been unsuccessful. As our gaps in the provision of allied health services in our central and northern sectors predominantly, both publicly and privately, increases, and with VARS growing to become a major provider of allied health services, VARS being the Virtual Allied Health Service, within our more remote locations, there is now an appetite to test new ways of working that takes a more district-wide approach to care with the capacity to maintain accountability centrally, to pivot for any future responses more flexibly as part of our business as usual. There are a number of reasons that contribute to the case for change to test the Rural Allied Health Assistance Service delivery model. This has included the inability to replace face-to-face clinicians as natural attrition has occurred over the years. The table in the slideshow to your left shows that there is a gradual decrease in on-site allied health clinical activity with a gradual increase in the virtual allied health activity happening in those northern and central sectors. So in 2021-22, VARS provided approximately 30% of the allied health activity in the central and northern sector rural facilities. Year to date, VARS is providing almost half, about 47% of that allied health activity in those northern central sectors. Because of the increased usage of virtual allied health, there are challenges with the required resources on the ground to provide the assistance with therapeutic interventions delivered virtually, making it labour intensive for nursing staff locally. And also we lack the necessary skills to do the required ongoing interventions considering an allied health approach to care. So our rural allied health assistant concept, in developing this model, we developed the model with a program approach across the 5 facilities. VARS oversees the scope of practice, the training and education, and we share governance and management responsibilities with the local facility line managers at each site. The position description that we developed was developed with the consideration of technology as an essential component of the role and passion to assist to help people as a must. These soft skills were considered integral with the idea that intensive training and frequent support from allied health clinicians will be put in place to effectively teach the rest that we require on the ground. This is why it was a pivotal to align it with our virtual allied health multidisciplinary team. The positions sit financially within the central virtual allied health team to allow the ability to pivot and respond to demands and future needs as they will present to us. So over to you, Katie.
Thank you. One of the critical things that we feel assisted us in starting our new role was the intensive 5-day orientation and training with the VARS team. This gave us the opportunity to develop good working relationships with the different allied health team members, learn a lot about allied health services and developed a close relationship with each other, so we now feel comfortable helping each other out and calling each other to ask questions to create a strong community of practice across the 5 facilities. This was essential for us as our health knowledge was varied, with a couple of the team not having any contact with health services previously, and some of us didn't know what all the different disciplines did. We just knew we wanted a job that made a difference. When starting in our facilities after the first week of orientation in a new role that no one else is doing, we needed to be clear on what our job was, what we could do and what we couldn't do and why. We also needed to feel at ease asking the VARS team sometimes multiple times a day questions to feel supported in what could be an isolated role. Orientation also gave us lots of opportunity to practice practical exercises and scenarios and go through the equipment that we would be using frequently to become competent with its use. 5 days that meant that we'd go over items that maybe have felt overwhelming on the Monday, but we were understanding it by Friday. 5 sites were identified to pilot the rural AHA program by rural sectors management. It was determined that the sites needed to be already good users of virtual allied health to further enable the service. Sites chosen are outlined on the map on the slide and include Narromine Health Service, Coonamble MPS, Warren MPS, Nyngan MPS and Gilgandra MPS. Coonabarabran and Lightning Ridge were also attempted to be recruited to with part-time hours, however, were unsuccessful. From a workforce strategy, one of learnings for the team is that recruitment to full-time should occur to provide this as a viable option for local community. Huddles occur twice a week with VARS and our formal supervision also occurs with one single person in the VARS team. This was Christy and now it's Anuna while Christy is on maternity leave. This has been ideal for us and we may have delegated tasks from several people and AH teams to have one person we go to for our formal supervision, and that tells us the same thing. It's vital for us to work without too many barriers. More frequent meetings may occur if we have shared a client with one of the multidisciplinary team. Since we started in our new roles in September last year, as a program, we have completed 1,744 occasions of service and provided a service to 232 people across our 5 communities. 75% of the people that we see either in the inpatient setting or residential aged care setting are 75 years or older.
So the rural allied health assistants have many tasks that they complete under the care of a multidisciplinary allied health team. The rural allied health assistant, as part of their roles, prioritise clinical facing work with the patients and clients. From the pie chart on the screen, you can see that 66% of their total activity is in person, and so that is not with anyone with them, that is them having one-to-one activity or intervention with the client or patient. 10% is in person with the allied health professional via audio visual, so that is the allied health professional coming in virtually and providing that high-level skill review or initial assessment. And then 24% is around case planning, including discharge planning, coordination, referrals, to ensure that we have that connected care for a multidisciplinary approach to patient care. One of the priorities that the Rural Allied Health Assistant is implementing that it has an impact on FORS is a functional, restorative and balanced program with our aged care residents. So 4 of our 5 sites have a aged care facility attached. There is approximately around 80 residents within those 4 sites. So since inception in the last 6 months, we have had a senior virtual physiotherapist with an rural allied health assistant on the ground complete individual functional assessments with all of those residents with consent. They have had either an individual targeted prescribed program, or they have been put into exercise groups with the rural allied health assistants, then performing those 1 to 2 times per week. This is something that has not been previously offered consistently due to lack of resources available locally. The next slide, we're I guess to explain, the practicalities of how the rural allied health assistant works. We do have 2 patient stories. The next one is Maxine, and Katie will describe her interventions with Maxine in terms of getting some really good outcomes for her. Over to you, Katie.
Thanks. Maxine is an 85-year-old resident living in Kalara House, Low Care within the Warren MPS. Maxine was mobilising independently with a 4-wheelie walker prior to a fall in October 23. Maxine sustained a fracture to the right superior neck of humerus. Following transfer to Dubbo Base, it was determined that conservative fracture management should occur. It was determined that Maxine would not undergo a shoulder reconstruction. On return to Warren, Maxine was moved to high care and was assessed as non-weight bearing. Maxine required all transfers as a 2 assist with a Sarah Steady due to her inability to put weight through her upper limb. Maxine's prognosis was that this was her new baseline functional status and that Maxine will never walk again. Virtual physiotherapy reviewed Maxine on return to the MPS with me in person and prescribed targeted shoulder range of motion exercises and leg strengthening exercises. I worked with Maxine daily and supervised Maxine performing her exercise program. Anuna Virtual Physio did weekly reviews with Maxine and me to conduct an assessment and provide prescription upgrades due to Maxine's positive progress. Due to this progress, Maxine was medically cleared to commence pain-free, protected weight bearing through her right arm. Maxine has now improved her mobility to walking with standby assist with a 4-wheelie walker. She no longer requires transfers using a Sarah Steady, and Maxine continues to attend the regular group exercise that I lead weekly.
The next story we have is around a virtual home visit. As the majority of the patients that we see across the northern and central sectors are aged 75 years of older, a service we do provide is virtual home visits and modifications to support a safe discharge home and reduce falls at home. Patients that are admitted they're at high risk of falling are prioritised by VARS to review their home and recommend and coordinate modifications prior to their discharge. This can be extremely challenging in the virtual space, with reliance often on community nursing or family members to participate locally. The Rural Allied Health Program has really enabled our virtual home service process to become streamlined and efficient. The next story is Raymond. So Raymond from Gilgandra has been willing to share his story on his positive experience with Amanda, who is our Rural Allied Health Assistant in Gilgandra, who worked closely with our virtual occupational therapist, Steph, who is located in Dubbo. So, Raymond, before my stroke, I lived by myself in Gilgandra. The stroke has affected my balance and ability to move around. My goal was to return home safely on my own, which I'm really pleased I have been able to do, thanks to some changes that have been put in place. My family was worried about me going home as they don't live in the same town as me. While I was in hospital, the Allied Health Assistant spent a lot of time with me and helped me to see different therapists. Amanda, the Allied Health Assistant, linked me in with the occupational therapist via a video. The OT talked with me about my life and my concerns and about managing my daily activities once I was home and what was important to me. Amanda went to my home and helped the OT to complete a home visit while I was still in hospital. After the OT looked at my home, she met with me again over the video and showed me pictures of my house and talked to me about where to put the rails and to help make it safer when I was walking around my house and showering. The OT arranged for rails at my front and back steps, modifications to my bathroom and toilet, and equipment in my home, as well as providing the essential education for me to use these safely. I didn't have long to wait for the rails to be installed at my house. I'm very happy with the changes. These small changes have made a big difference to my life. They certainly help me make everyday activities easier, and I feel more confident being home by myself. My family also feel more comfortable knowing things are in place at home to prevent me from falling while I'm on my own. So before finishing up, I would like to acknowledge some key people that have been instrumental in getting this program implemented. Christy Gator, who has been our clinical lead since inception, would not have been able to get this up and running without her clinical expertise and patience. Christy couldn't be here today because she's having a baby literally today. So her apologies to the group. The Virtual Allied Health team for being flexible and dedicated to try new ways of working in supporting the bigger pictures and testing possibilities of what our future services could look like. And our partners, which are the 5 rural health facilities, they have been extremely engaged. They provide constructive and timely feedback for us to continually improve this service. And we've had fantastic support locally for our Rural Allied Health Assistants. And finally, the Rural Allied Health Assistants for taking a chance on these roles. Their skill has been significant and their dedication locally has really shaped this service. So thank you for your time today. I've only given you a snapshot of what this program does in relation to falls. If you would like any more information, please do not hesitate to reach out. My details are on the slide.
Thanks, Di and Katie. That was just fabulous and so great to see those alternative models of care really working out in our districts, and hopefully some more funding will be available in the future to enable it to spread a little bit wider. And there's always stuff that other people can do in other sites that haven't got that particular funding. But yeah, I'm sure that's given you lots of good ideas. So thanks, that's great.